Welcome, and thank you for choosing to join Dr. Beth Carlin and Ms. Paula Anastasia, along with patient panelist Carol Takeshi, for Part 3 of a 3-part webcast series, PARP Inhibitors in Ovarian Cancer, Current Advances and Future Directions in the Treatment Paradigm. This is an educational series supported by an independent educational grant from GlaxoSmithKline and presented by Creative Educational Concepts. To claim credit for this webcast, recognizing and addressing the elephant in the room, multidisciplinary strategies to mitigate disparities in ovarian cancer patients, be sure to complete the post-test questions and the evaluation. This webcast is moderated by Dr. Beth Carlin, Professor and Vice Chair of Women's Health Research, Department of Obstetrics and Gynecology at the David Geffen School of Medicine at UCLA. We will begin with a short didactic presentation by Ms. Paula Anastasia, an advanced practice nurse at UCLA Health in the Department of Obstetrics and Gynecology. After Ms. Anastasia's slide presentation, we will conclude the webcast with an insightful discussion between Dr. Carlin, Ms. Anastasia, and one of their ovarian cancer patient survivors, Carol Takeshi.
Thank you, everybody, for hanging around for this third medical moment. This will be an exciting topic when we're going to talk about recognizing and addressing the elephant in the room, multidisciplinary strategies to mitigate disparities in ovarian cancer patients. Clearly a very timely topic, and we're joined today by Paula Anastasia, who is an advanced practice nurse in my practice. I'm lucky enough to work with Paula for almost 20 years now. She's an advanced practice nurse at UCLA Health here in Los Angeles. And Paula will be discussing with us her experience, and how do we best deliver care to all women with ovarian cancer. The learning objectives for this medical moment will be to review risk factors to guideline-recommended genetic testing and treatment in ovarian cancer, including access to care, race, comorbidities, socioeconomic factors, education, and insurance status. And then evaluate challenging ovarian cancer cases, focusing on health equity issues, strategies that a multidisciplinary team can employ to help mitigate modifiable healthcare disparities in their patients. Clearly a very timely and important topic. And with that, I'll hand it over to Paula Anastasia.
Good day, attendees, and thank you for your commitment to patient care and outcomes. Quick overview of the statistics for 2022 ovarian cancer. Over 19,000 women will be diagnosed this year, and unfortunately, half of those women will die of their disease. It's not the most common of the gynecological malignancies, but unfortunately, it is the most fatal. We know that new cases are decreasing each year, and also death rates are decreasing each year. The 5-year relative survival rate is almost 50%. The majority of women will be diagnosed in advanced stages, usually stage 3, and the majority of those will be high-grade serous. The 5-year survival rate has increased in non-Hispanic white women, but sadly, that survival rate has decreased in the African American women. So we talk about healthcare disparities, and I think that we're all aware of that. But how do we overcome it? And the barriers, just in review, the number one is access to care. And we look at survival trends, and we know that women that have surgery by a board-certified GYN oncologist have a better overall survival. So where are these GYN oncologists? They're in the high-volume facilities. They're the ones that are doing the most surgeries, increasing that survival. So therefore, the access to care, we need to make sure that when women are diagnosed or suspected of this unfortunate disease, that they are being referred properly. So we know in the rural settings, these women may not have the best GYN oncologist. They might not even have guideline adherence care. So this is something that we need to do better. And I think we're aware of it, but how do we overcome it? How do we encourage and educate our practitioners to be more proactive to help with these referrals? The other thing that we're finding out, and if you've listened to the other webinars, and we're highlighting new treatments and PARP inhibitors, is genetic counseling is a must. This is mandated or recommended by all the national societies now, Society of SGO, Society of Gynecology, Oncology. We know it's recommended by ASCO, and genetic counseling is not available to all women, especially Black women and the underserved. And one of the reasons, again, is not everybody is doing genetic testing, even though all women should have genetic testing. So in a rural setting, for instance, maybe they don't have access to a genetic counselor on site, but these patients can still have testing, and there's telemedicine, and there's national societies that can also counsel women through telemedicine. So I think the awareness, even now in an academic setting that I work in, we have patients that are referred to us still have not had genetic testing. So I think we still need to get the word out. We know that Black and Hispanic women are less likely to receive guideline adherent care compared to white women. And we know that they're also not getting genetic testing. So earlier I had mentioned that there is a decrease in incidence. Do you think perhaps that could be that women that are having genetic testing, that when you do cascade testing, that you're offering risk-reducing surgery to the family members or to these women in the family that also have the mutation? But if Black and Hispanic women are not being identified as mutation carriers, we're not limiting survival patterns in that population. We know education is really important so that women know what the symptoms are of ovarian cancer so that they will initiate a visit to their physician. We also need to educate the physicians and the practitioners that are seeing these women that have settled symptoms to say, hey, this is not in your head. This is not just bloating or weight gain. This is something that needs to be looked at. And we also know that women who do not have coverage insurance that allows them to choose their provider also are not getting adherent guideline treatment or referrals to GYN oncologists. So looking at pathogenic variants for patients that should have genetic testing because they've been identified as having ovarian cancer, we know that it's across all ethnic groups, but sadly, all ethnic groups are not having standard of care genetic testing when they're diagnosed with ovarian cancer. We know, of course, in the Ashkenazi Jewish population that the incidence is much higher, but for non-Hispanic Blacks, Hispanics, and Asians, it's still comparable. So all of these women need to have genetic testing. And I think because I work in an academic setting, I'm thinking, well, this is not new information, but sadly, it's still not being done. Black women are less likely to have germline genetic testing. So therefore, if they're not being tested, they're not getting standard of care treatment when we look at maintenance therapy with PARP inhibitors, which we know that patients that have genetic testing and somatic testing, that dictates their maintenance and future therapy. But we also know if these women are not having their genetic testing, how are we going to help the family members that also carry these mutations? I learned a lot when COVID hit and looking at those who chose to have vaccines and those who did not. And a lot of the conversation was about trust. And it really opened my eyes as the medical mistrust in the Black community. It really brought that awareness even more so than I thought that I knew. So I think that's really important when we talk about clinical trials as well. So if these women are not being offered or enrolled in clinical trials, they're also not getting standard, or not standard, but state-of-the-art treatment that can improve their overall survival. So look at this study by Dr. Bristow. Over 50% of patients with ovarian cancer were treated at low-volume hospitals by low-volume physicians. So once again, you need a board-certified GYN oncologist to be doing these. There's enough cancer out there for general surgeons and gynecologists, but we really need to refer these patients. So if a patient is suspected to have ovarian cancer, or maybe they had cytology from a thoracentesis or paracentesis, they may be getting neoadjuvant treatment by a medical oncologist, knowing that they're going to need interval debulking surgery later on. So it's also the ownership of the medical oncologist to make sure that these patients are being properly referred to the right and the best qualified surgeon, GYN oncologist. So again, looking at the racial disparities, once again, for patients that are being treated at low volume hospitals, there is a less overall survival. Just looking at the Medicaid expansion helped decrease cancer care related healthcare disparities. So this is due to the Affordable Care Act. Now, this is only looking at 2 years. The patient population was not ovarian cancer, but again, it set the trend that patients that have insurance and access to care, there was an improvement in screening and a decrease in survival in their cancer. So once again, this is really important information. So looking at clinical trial participation, once again, trust. We need to involve all our patients and offer them clinical trials. If we don't have a clinical trial at our setting, I think it behooves us to know what clinical trials are available in the community. In some situations, patients can travel. That's not always, again, healthcare disparities, travel to another state, but it's important for us to be aware of what clinical trials may benefit our patients. Underserved patients are much less likely to enroll. And then we talk about implicit bias. And I think sometimes that I've overheard, we're not going to ask that patient because she lives too far away and she can't afford transportation. And I think that is really unfair as well. We need to offer these patients the opportunity to say yes or no. And we also know there's resources out there. And again, not every facility is equal also that has resources, but can we get financial counselors? Can we get social workers? Because there are things that we can do for patients that have financial limitations, travel for one. There are vouchers and that sort of thing. Some of the clinical trials are designed to offer transportation and housing stipends. So again, I think it's important for us to at least offer these patients clinical trials so that they have the opportunity to have state-of-the-art treatment and possibly increase overall survival. Looking at GOG, retrospectively, showing that the majority of the participants are Caucasians. And so once again, we need to do better. I think we're aware of it, but now we need to actually do something and start offering these patients enrollment in clinical trial. We know also that patients that are in clinical trial may have better overall survival, but if they're not being offered clinical trials and new state-of-the-art therapies that could potentially increase their survival, how are we going to know? So this is, again, really important for all of our patients to be offered and allow them to have the opportunity to say, no, I'm not interested in this. I think also when we are talking about education, patients' educational level, I think sometimes, and again, this is just personal experience, sometimes when you offer a patient a clinical trial, especially if it's a phase 3 and it's a standard of care plus a novel agent or standard care and a placebo, they think they're getting only placebo. So I think our education is also equally important to remind patients that we are offering them standard of care plus something that might make their survival even longer, and really emphasizing the ethical purpose of this. So I think, again, what do patients understand? What is their past experience? And patients that English is not their primary language, making sure that we are having facility-based interpreters, not family members. So again, helping patients understand what is available to them. And again, choices and options, because many times there's more than one treatment choice. Looking at PARP inhibitors, and if you've attended the other webinars, which I hope that you have or will, we know that PARP inhibitors are really making a difference. Research shows that they have a better clinical response if they have a germline pathogenic variant or a somatic or homologous recombinant deficiency in their tumor. So our patients need to have testing to determine who may have a clinical benefit and again should be offering this medication. So again, reviewing 15 phase 2 to 3 clinical trials of PARP inhibitors. Once again, the Black and the Hispanic women were not in these trials. So how do we know how they are doing? And once again, if they're not having genetic testing, how are we going to know who should be getting this and who would have a more or a better clinical benefit having a PARP inhibitor? So once again, I'm repeating myself. I know you guys are aware of this, but it's important that we start implementing what we should do better so that we can improve survival and outcomes in our patients. So once you've achieved and obtained these results, how do you determine which PARP inhibitor you are going to prescribe? So it's important, again, individualizing. Your patient may be eligible for maintenance after primary therapy. The patient may have had a first relapse and now in remission and get a maintenance therapy, or as I mentioned, recurrent therapy. We want to look at the molecular testing and the biomarkers. There are indications if a patient does not have a biomarker that there are FDA approvals for these patients. What is the patient's prior adverse event or side effect from their primary chemotherapy? Did this patient require growth factors, or were there dose delays, or did the patient have a lot of anemia? Because this may impact when you're dosing your patient and also your monitoring of their blood count. So that's really important. Drug-drug interactions. Do patients have polypharmacy where they may have better adherence if they're just taking a pill once a day versus twice a day? Again, you want to individualize this. There's been studies saying that daily versus BID doesn't really have a difference, but you know what? I want to talk to my patient. I want to know what works for them, what medications they're on, and obviously cost and insurance. So hopefully in your setting, you have somebody that's doing this. In my setting, I'm usually the one doing this, but there are financial counselors, there are navigators, there's oncology clinical pharmacists, and cost and insurance are huge when you're doing oral medications. And oftentimes we will do all the paperwork and we'll get this information from, or get the medication from a specialty pharmacist, and they send it to the patient. So the physician is kind of out of that loop other than prescribing, but many of us are doing the behind the scenes paperwork. They will contact the patient, let them know how much it costs, this and that. Some of these medications are so expensive. I've had patients that have had zero copay. I've had patients that have had 12,000 and everything in between. So again, physicians may not even be aware of this, and patients are proud. They're not going to tell you I can't afford this. I mean, many do when there's $12,000, but for some patients, you know, they may sell things. I've had patients that wanted to put their house up for sale. They borrow money. So these are really things that transparency, we need to be discussing this. So again, how can we help them? What aid, what copay assistance? And again, yeah, sometimes it takes a lot of work. And I'm not asking the physicians to do this. That's what we're for. But I think they need to be aware of this. And sometimes if one medication is too expensive, we might go to a different company. But I think we as nurses, we underutilize the resources that are out there, especially industry and the copay assistance. And I've been very happy that I'm not too proud to say, hey, I need help. I'm too busy to do all this paperwork, but this is my barrier. Is there anything you can help me with? And usually they will come forward, but you got to ask, right? So some of the themes for non-adherence, we know that patients that are motivated to take their medicine, obviously they're going to be more adherent. My ladies with ovarian cancer, they're like, oh my gosh, if I can take this medicine to prevent or delay a recurrence, I'm going to take it. But there's side effects. So there are times where it's like, oh my gosh, I'm nauseated or not so feeling so well. And they may skip doses, but not tell you. Or patients may, again, may not be able to afford them. So they are kind of stockpiling them. I've had patients take half the dose so that they can save them. There's many, many reasons. So I think talking to our patients, asking our patients how many doses they have missed, as opposed to, are you taking your medications? We also know that there are some patients that coming into the office to see their oncologist, to see their nurses, that's kind of their safety net and their emotional safeguard. So sometimes we say, well, you're taking an oral medicine, you take your get your labs monthly, and we'll see you every 3 months. And they're like, oh, no, I'm way too vulnerable. I can't just see you every 3 months. So again, sometimes patients are like, I don't want to be on oral medicine if I can't see you more often. So there's lots of things. And so we need to be talking to our patients about what works for them, what doesn't work, but also providing the rationale for why we are prescribing something. And again, with PARP inhibitors, we know that we can delay or prevent a recurrence in many of these patients that have a germline or somatic pathogenic variant. So just real quickly, talking to your patients about there may be the side effects, of course, but also that one size does not fit all. So I often tell my patients, I said, remember when we gave you IV therapy, height and weight is how we determine the dose. Well, many of these drugs are FDA approved as one dose, but your body is different sizes, metabolism. So one size does not fit all. So there will be times when we may need to dose delay or dose reduce. And sometimes that can be very difficult for patients. And then when we talk to them about, you're going to be on this medication for 2 years, because after that, there may be risks of long-term side effects, and patients are like, well, oh my gosh, I can't just stop. This is my lifeline. So again, a lot of discussion, reassurance, and reassuring your patients that, we are here for them and we're going to help them. Side effect management, I know there's been in other webinars, which you may or may not have clicked into, but we do remind our patients that fatigue and nausea and changes in their blood counts are the most common, or the class effect. And that's why we do want to check their blood counts monthly. And we are looking for anemia. We're looking for a decrease in the white blood count. And our goal is to keep them safe, but we also need to find the right dose for them. So in review, again, because we're in healthcare, I think some of this is like, oh, I already know about healthcare disparities, but what can we do to improve so patients have adherence, so patients are getting the best standard of care in all patients, not just specific patients of ethnic group or socioeconomic groups. So we do need to provide education to all our patients. So when they're newly diagnosed, letting them know what standard of care is, let them know that genetic testing is part of standard of care, that maintenance therapy is now standard of care. So all of the things. Now, of course, they're only going to remember a little bit of this, so constant reinforcement and reminding them of this. But shared decision-making, what is the patient's goal? What do they want? What works for them? So again, we're partners in all this, and we really need to communicate and be transparent. How much information do patients want? Sometimes patients are like, I just want to know today. I can't worry about long-term, and I don't want to know anything that's negative. But we need to do this together. Healthcare barriers, again, insurance is really important, transportation, access to care, referrals, clinical trials, all of those things. And if we are fortunate enough to have resources, social workers, palliative care for symptom management, spiritual, even there's online resources. There's, the ovarian cancer societies and patient organizations that can help patients also. So there's so many things that we can offer patients that we probably could do better at. So again, we're a team, and the patients need to be partnering with us, what works for them, what they want. So communication, decreasing biases, easier said than not. I know that it's been stated that patients do better, connect better when their healthcare professional looks more like them. So I can't do anything about that, the color of my skin, but I can individualize, ask patient what matters to them. Tell me about your lifestyle, your values, those types of things. Would it be helpful if I introduced you to a patient that has gone through similar experiences? 30 years of doing this, I can empathize what it's like, but I don't know, right? Because I've never walked in those shoes. So again, providing what we can to patients, always be honest, communicate, pay attention to the cost. And again, I'm focusing on the physicians, but there are all of us as a team. So there's somebody here that can help that. So ask your navigator, ask your nurse, ask your financial counselor. We need to really pay attention to the financial burdens that these patients are going to. And like I said, many times they're very proud and they're not going to disclose that. Clinical trials, I cannot emphasize that enough. And again, instilling trust in our patients, valuing them not as a person with cancer, but as a human being. And they have families, they contribute to society. What did they do? What was their life like before they came into this office today? What's important to them? Those are the things that make us do what we want to do so that we can help these patients live longer and live better. And I really appreciate you being here and listening. But the most important part of this webinar today is listening to Carol. Carol was diagnosed with ovarian cancer in 2017, and I would like you to listen to her full-heartedly. And as we always say, it's been a privilege to know her and take care of her, but she is a well-rounded human being, and she just happens to have cancer, but that is not who she is. Carol, I'm going to let you take this away.
I'm an ovarian cancer survivor, which is a new word for me, a 71-year-old Japanese-American woman, a mother, sister, and grandmother. I was originally diagnosed at stage 3C in early 2017 and was privileged enough to have Dr. Carlin as my oncologist and surgeon and Paula as my nurse. Since my first visit with Dr. Carlin, I felt I was in very good hands, given her knowledge, skill, frankness, but also such an encouraging outlook. And that makes a big difference to cancer patients. And that's especially true because I was really a mess. I was sore, bloated, with a bloated abdomen filled with ascites fluid and so much uncertainty. And I will always remember my nurse Paula's warm, very reassuring hand holding mine as I lay down on the examining table for that first time. And it's an important beginning to my journey. So I went through chemo, was in remission for a little over a year, then had a recurrence at the end of 2018. After other rounds of chemo, I was very glad to have the option to take an oral drug, rucaparib, a PARP inhibitor, and that was something I could live with. It had just been approved by the FDA not long before my recurrence, and I fit the profile for someone with tumors likely to respond. I Googled a lot about PARP inhibitors and their impact on life expectancy. So I knew they weren't a cure, but they could at least keep the tumors from growing for hopefully a year or more. Plus, as Dr. Carlin pointed out, in the meantime, there were so many other possible treatments being developed that could be explored if I couldn't tolerate or stopped responding to this medication. The main side effect was a big drop in my white and red blood cell counts. It took about 5 months to get the right dosage. Luckily, Dr. Carlin was persistent and willing to personalize my dosage until it was right. I also had chronic fatigue and constipation, managed by a nap whenever I would hit a wall, and Miralax and Colace every night. For me, not bad trade-offs for keeping the tumors in check. I adjusted to these minor side effects, and my tumors even began shrinking. My checkups with Dr. Carlin were very encouraging, and of course it helped a lot when she would often greet me by announcing, "You're a rock star," when my scans would keep showing improvement. At the beginning of rucaparib treatment, my main concern, besides getting the right dosage, was getting funding to pay for it. I learned that oral chemo drugs in general are extremely expensive, maybe up to $12,000 per month or more after insurance payments. I was very worried and really incredulous about the possibility of not being able to continue on this life-saving medication due to the cost. My medical team suggested I could get some kind of assistance, and some women in my gynecological cancer support group and the social worker and nurse who lead it confirmed this even though one of the women in the group had to pay $3,000 for her first couple of months of treatment on PARP inhibitor. Gratefully, my nurse Paula connected me up with people who could help me get a grant. It was not difficult at all, filling out some forms, and I was so relieved when I learned that I had been accepted. I then was able to help my sister-in-law get her oral chemo funded for a different kind of cancer. But after she had to pay $10,000 for her first dosages. Her primary language was Japanese, so she had more difficulty navigating the grant approval process. So her first application was rejected and she gave up. She told me that she could file an appeal, but what was the point? I encouraged her to advocate for herself, and her nurse happens to speak Japanese and was able to help her file the appeal. And I walked her through how to fill out the form correctly. So soon she was able to be approved as well and get this life-saving medication. Things went smoothly for me on the financial front for maybe 6 months before my grant ran out. And I kind of lost my breath. But then the pharmaceutical company continued to find grants for me, and I was able to be covered for the whole time that I was on the PARP inhibitor. I was able to keep working until I finally retired during the pandemic. I've been able to continue my political activism and concerns about the world and humanity. And I've been able to take vacations to Mammoth and Big Bear with my extended family and my grandchildren. And meantime, my tumors continued to shrink. So in a lot of ways, the PARP inhibitor was like a wonder drug to me. And I am so grateful and really in awe of what science has been able to accomplish. I have to say, I was very disappointed when I learned that I could only be on the drug for 2 years due to possible serious side effects. It took me quite a while to accept the fact that I would have to stop taking the drug that was holding my tumors at bay. But Dr. Carlin was firm about this, and I very much trust her judgment. Still, I Googled PARP inhibitors and some of the side effects, and I could see she was right. I mentioned my concerns to Dr. Carlin that my tumors would begin growing again. And she said she wasn't so sure they would, at least for a while. And if they do come back, there are still other treatment options. I'm hoping, if it is possible, that I can go back on a PARP inhibitor at some point if needed. But I understand there are other new options constantly being developed. When I did stop the PARP inhibitor in July last year, I told people I felt like I was flying without a safety net. It's only after months have gone by and scans show continued slight shrinking of the tumors that I've begun to feel more confident and able to feel for now that I'm doing good and can concentrate on living and contributing. Thank you, Dr. Carlin, Paula, medical science, and human knowledge and caring.
Paula and Carol, thank you so much for that incredible and inspiring medical moment there. Carol, it's thrilling, rewarding to see you thrive, to see you now be an advocate for others as well as a survivor, and as you said, such an important member of your family and community. So seeing you help others and then share your story with everyone today. Thank you so much here. It's so important. And Paula, your presentation was, really right on point there. So when you think about what strategies do you think we can really use to improve recruitment of underrepresented minority women onto clinical trials? Is there anything you found in, your experience and your readings that we should particularly target?
Well, I think it's important to be aware of the clinical trials. I think all of our patients that come to us, that we need to let them know what the standard of care is. But in addition, there are clinical trials available. And I think we really need to start offering these to every patient. And I think even, our colleagues, many of us have tumor boards and meetings in our facility to be sharing what are the clinical trials available, what are our associate facilities that have clinical trials going on. And, sometimes it's like, oh, well, I don't want to refer my patient to another setting. But our goal here is to improve outcomes and survival. And so I know that you do this, Dr. Carlin, and if there's a clinical trial that we don't have, but may be of benefit at another facility, to let the patient be aware of that. We're still going to be your team, and you can come back to us after that clinical trial. But I think it's really important to share this information to all of our patients. And I think when we go to societies, the Oncology Nursing Society, I think it's important for us to be sharing every day, what is your patient doing? Do you have any new exciting treatments that you're treating that I should know about? Sharing of ideas.
And I think something you brought out and Carol did as well, in our shared decision making, making sure our consents are in appropriate languages. I mean, that's sort of a legal requirement, and that there are appropriate interpreters so that to achieve the shared decision making, you have to be able to listen, and the patient has to understand these opportunities as well. And I think, Carol, you highlighted that, especially with your sister-in-law, how you helped, as well as her nurse in the practice there, making sure that she could get the cutting edge treatment that was available to her. So I think that's one thing, is trying to overcome a language barrier. And the other thing, especially in under-resourced settings, I know in our practice, you act as the nurse navigator as well, but I think studies have really shown often for underrepresented women that having a navigator to help them, as Carol, you pointed out as well, having someone to help you getting the grants, what was necessary. The energies in many practices are not as high as often Paula reaching out, but we do need to use navigators more effectively, I think, especially in under-resourced settings, as one way to help overcome that.
Because it's a lot of work, and it's very frightening for patients, not knowing what avenues and what options are out there, and it's also very time consuming. So you need that extra person to be able to help get the person from A to B, whether it's a patient navigator, a nurse navigator, a social worker. But like you said, we need a multidisciplinary team.
And I think, Carolyn, your comments of thanking science and medical knowledge, we as taxpayers in this country really fund, through the NIH, National Cancer Institute, so much of the research that has led to these breakthroughs. And I think one of the concerns about this elephant in the room of these disparities is that unless we have access for everyone, we're going to further widen these healthcare gaps if not everyone can have access to the same medicines and the same testing. Both genetic testing and tumor molecular profiling may not be covered by some insurances. And I think having that voice and that advocacy, we are fortunate, similar to the pharmaceutical companies that help provide access for you to the PARP inhibitor. Often the genetic testing companies similarly will help provide access to that testing if it's not being covered. But to be able to prescribe the right medicine and have access, and what I would say is to democratize the discoveries to everyone in need, has to be one of our core values in healthcare as well. So thank you for highlighting that. And then tools, I think you both brought up, again, assessing financial toxicities. I think, Paula, you started discussing it about understanding the patient, what are those stresses?
Yeah, and I think that we use that term financial toxicity, but again, with all due respect, I don't think the physicians really know the impact of how expensive these medicines are, because again, I'm doing the paperwork, the specialty pharmacy may be directly contacting the patient with the cost. And so we may not really know the burden. And like I said, many people are proud, or they think, if I don't take this medicine, I'm going to die. So I have to get this money. But knowing that there are resources out there, but again, that takes time. So if you're in a facility that's not well staffed and overworked, and it's sometimes it's like, the ball just gets dropped.
Awareness, as you noted, I think so often everyone wants to be perceived as being a good patient. We don't have those preconceived notions, so not to complain and not to bring this up. So I think the awareness, the asking, and I think when I think of financial toxicity, it's not just the needing perhaps to say, I'm going to take a reverse mortgage on my home to pay for my drug, but the stress that imparts on the patient and her family actually could reduce the effectiveness of the treatment. That we know that stressful life situations are a comorbidity that impact the effectiveness of treatments. So I think thinking of it not just as a dollar amount, but its impact on the patient's survival potentially. So I think it's an important part of our history, something that we need to think about. Be honest with yourself about implicit biases, assess it if you can't, and really trying to think of every person in the same way with a standard operating procedure of thinking about clinical trials, thinking about tumor molecular profiling, genetic testing for everybody, and educating them about these opportunities and respecting their individuality as well. So with that, I want to once again thank both of you. A special shout out, Carol, you are a rock star. Thank you so much for being here with us today. Thank you, Paula. Thank you to CEC Oncology for these medical moments. We hope that our information today about PARP inhibitors in the upfront maintenance setting for ovarian cancer will be helpful for you as you care for the women in your practice with ovarian cancer. Thank you very much.
Thank you.
Thank you again for joining us for this educational webcast series focused on mitigating disparities in ovarian cancer patients. To claim credit for this webcast, be sure to complete the post-test and the evaluation. Also, be sure to access the other webcasts in this series. Webcast 1, Digging Deep into the Genome, What Genetic Testing Can and Can't Tell Us About Ovarian Cancer. And Webcast 2, Appraising Current Safety and Efficacy Data for PARP Inhibitors in Ovarian Cancer, Best Practices in Treatment and Adverse Event Management. Thank you for your participation.